Good morning. So we are having our clinical class today. Today, a case presentation by Dr. Malavika Rao, second year generation at Apollo Multi Hospital, Kolkata. She will present a case of carcinoma penis, followed by we'll have a discussion on operative steps. Dr. Sanjoy De Bokshi is a VIT teacher. He's a very renowned teacher in Calcutta. He will take us through the case scenario. Professor De Bokshi is with us. Malavika can start.
Thank you, Professor Shah. Thank you.
Good morning, sir. Can you hear me?
Yes, we can hear you, Malavika.
This is a case of carcinoma of penis. Next slide, please. Yes, my patient, Mr. X, is a 73-year-old male resident of Guwahati, Assam. Is a farmer by occupation. He presents with the chief complaints of a non-healing ulcer over the tip of his penis for the past 5 months and the inability to retract his foreskin completely over for the past 1 month. Next. My patient was apparently all right 5 months ago when he noticed an ulcer on the tip of his penis. The ulcer was insidious in onset and gradually progressed from an initial size of 0.5 by 0.5 centimeter into a small mass of 2 centimeter by 2 centimeter. It was initially painless, but 3 months ago he felt pain over the ulcer, which was sharp in character, non-radiating and non-transmitting, without any relation to the act of urination, and subsided spontaneously. The ulcer was also associated with an occasional scanty, blood-tinged, foul-smelling discharge, which also subsided spontaneously. Over the past month, 1 month ago, he complained of inability to retract his foreskin completely. There is no history of fever, burning micturition, hematuria, or poor urinary stream. There is no history of swelling in the groin, abdomen, or any other part of the body. There's no history of weight loss, loss of appetite, fatigue, chronic cough, hemoptysis, or jaundice. There is no history of redness or whitish discoloration of the foreskin. No history of similar complaints in the past. On past history, he is a known diabetic and hypertensive on medication for the past 10 years. No past surgeries, no major ailments in the past, or no hospitalization. No history of circumcision in his childhood. On personal history, he is a known chronic smoker for the past 30 years and smokes around 52 packs per year. No history of unprotected sexual contact in the recent past. He has normal bowel and bladder function, normal appetite, and no known allergies. Family history, he has no known cases of cancer in his first-degree relatives. Treatment history, he sought treatment with a local physician and was prescribed local topical antibiotics, but did not feel any relief from his symptoms. And he received no other intervention. Summary, Mr. X is a 73-year-old gentleman who's a known diabetic and hypertensive and chronic smoker. He came with the chief complaints of an ulcer over the tip of his penis for the past 5 months and inability to retract his foreskin for the past 1 month. The ulcer was insidious in onset and gradually progressive in size. It was associated with occasional pain and intermittent blood-tinged foul-smelling discharge from the ulcer. He received antibiotic treatments from the local physician for the same, but experienced no relief. There is no history of burning micturition, unprotected sexual contact, poor urinary stream, any swelling in the groin or abdomen, and there's no history suggestive of distant metastasis.
So Malavika, I mean, with that sort of a history, what is your provisional diagnosis and what do you want to consider as differential diagnosis?
My provisional diagnosis is a non-healing ulcer on the non-healing ulcer on the tip of the penis, which is most likely carcinoma, which is most likely neoplastic. Differentially, he could, if my history is unreliable, then he could have a sexually transmitted disease like gonorrhea, chlamydia, syphilis.
Would gonorrhea present with an ulcer of the penile region?
It presents with urethritis and occasionally a small ulcer.
What is, I mean, of the two diseases like syphilis and gonorrhea, which traditionally, historically, which was the disease that was associate with a painless ulcer on the tip of the penis?
Syphilis.
And what is that particular ulcer called? Do you know what the particular?
Hunterian chancre.
Yeah. So it's called chancre.
Chancre.
Yes, that's right. Now this patient is a diabetic. So how would you differentiate, how do you justify that this might be a non-treated diabetic, and he might have developed a balanitis and might have developed a number of infections. Like you could have a fungal infection, for example. He's a diabetic, isn't it?
Yes, sir. Firstly, sir, he has no history of trauma. He has no past history of similar complaints like inability to retract his foreskin. He has no poor urinary stream, which excludes phimosis and balanitis. And diabetic ulcers are usually ischemic ulcers, which do not have, on examination is how I differentiated it. So.
Okay, could he actually retract his foreskin before? You didn't mention that.
He could retract his foreskin completely, yes, sir.
Professor Shah, do you want to ask any questions?
Yeah, the point is, once Dr. Deboksi asked you about the DD, yes, I always say you make a DD of the presentation.
Okay, sir.
You cannot, you have already described he has got an ulcer in the tip of the glans, which is about 2 centimeters in size now.
Yes, sir.
With false film discharge. So he cannot bring a DD of gonorrhea in this patient. So
okay.
You bring a DD of a proliferative mass in the glans penis.
Okay,
one
sir.
DD is malignancy. Yes. Second can be a Buschke-Lowenstein tumor, which is a form of varicose carcinoma. And tuberculosis comes everywhere. Okay, it can be a chronic infective lesion like tuberculosis.
All right.
And you have asked in the history about jaundice, cough, hemoptysis.
Yes, sir.
Are these very common in a patient of carcinoma penis to have metastasis to the lungs or to the liver?
No, sir. It's very uncommon, but I want to rule out any distant metastasis.
So the more common site of metastasis is the nodes.
Lymph nodes.
So carcinoma penis is a slow-growing tumor, and distant metastasis is very remote. Okay, yes, but for just sake of completion, you have those. Agreed. Yes. So. Okay, Dr. Deboksi.
We can go to examination then, Professor Shah, if you agree.
Yeah.
On examination, I examined my patient with his consent in a well-lit room and with adequate exposure. I examined him in supine position. On general examination, his BMI was 30.29. The patient was alert, conscious, and cooperative. His pulse was 68 beats per minute regularly, without any radial or radiofemoral delay. BP was 130 by 80 millimeters mercury in the right arm in supine position. No pallor, edema, lymphadenopathy, icterus, cyanosis, or clubbing. On local examination, I exposed him from the umbilicus to the mid-thigh level. On inspection, there is a single irregularly shaped ulceroproliferative mass on the right side of the glans penis, continuous with the overlying prepuce, extending distally 0.5 centimeters from the urethral meatus till the coronal sulcus proximally, and measuring approximately 2 centimeters in diameter. It has an uneven surface with patches of white flakes, irregular margins, and everted edges. The floor of the ulcer is covered with necrotic unhealthy tissue, a granulation tissue. The urethral meatus appears normal. The rest of the external genitalia, scrotum, and both inguinal regions appear normal. Next slide, please. On palpation, the swelling is confirmed to be non-tender. The local temperature is normal. The inspectory findings were confirmed. The growth continues onto the overlying prepuce, and hence the prepuce does not move freely over the glans penis. The base of the growth is indurated and does not involve the shaft of the penis. There is no discharge from the ulcer or from the urethral meatus and applying pressure over the lesion, and the rest of the penis is normal. Scrotum and testes are normal. No palpable inguinal or pelvic lymphadenopathy. On DRE, prostate appears to be normal, and there is no abnormality detected on systemic examination. Summary: There is a single 2 by 2 centimeter ulceroproliferative growth on the right side of the glans penis, continuous with the overlying prepuce, extending from the coronal sulcus, approximately 0.5 centimeters from the urethral meatus distally, and distally. It has an uneven surface, irregular margins, everted edges, and the floor is composed of unhealthy granulation tissue and has an indurated base. There are no signs suggestive of active inflammation. The prepuce cannot be moved freely over the glans penis. The rest of the penis, scrotum and testes are normal. There is no palpable inguinal or pelvic lymphadenopathy.
Malavika, you said that this was free from the shaft of the penis. Now
Yes,
that
sir.
is going from the gland. So
Yes, sir.
how did you say that this lesion was free from the shaft?
Sir, I examined with both my fingers and made sure that there was no corporal body involvement. It was the lesion was strictly restricted to the glans penis, sir.
Okay. Isn't there, I mean, would it be, I mean, what you meant was the body of the shaft of the penis wasn't involved, isn't
Yes,
it?
sir. Yes, sir. The body of the, yes, sir. Sorry.
So how would you differentiate a penile structure? I mean, what are the different parts?
There is the in the shaft of the body of the penis has the corpora cavernosum.
Say the parts of the penis. The first question is, what are the parts of the penis?
The parts of the penis. Okay, the penis is divided into the root, the body, and the glans. The root is located in the superficial perineal pouch. The body is which is not visible to the visible in gross examination. The body of the penis, which hangs from the pelvic bone, is the visible part, and that has the corpora cavernosum and the corpora spongiosum. The corpora cavernosum is on the dorsal surface, with the corpora spongiosum is on the ventral surface. And the glans is just an enlargement of the corpora spongiosum, and it provides the head of the penis. Just the last.
Okay. What is the glans a part of? Is it a part of any of your erectile structure?
It's a part of corpora spongiosum. It's the enlargement of the corpora spongiosum, sir.
Okay, so what you actually meant was there wasn't any involvement of the body of the penis, not the shaft,
Yes,
really.
Yes, sir. The body.
Okay, so you need to be slightly careful of your terminology out there, Malavika.
Okay, sir. Okay.
Right. You also said that you had a foul-smelling discharge.
Yes, sir.
So what about the edges? Was it?
The edges were everted, sir.
The edges were everted. If you had an undermined edge,
yes, sir.
It would
be more suggestive of a tuberculous ulcer.
Okay, that's right. You also said that you felt for the entire body and you didn't find any involvement. So what are the structures in the body of the, on a cross section, what are the structures in the body of the penis?
On the cross section, there are two corpora cavernosa on the dorsal surface on either side, and in the ventral surface, there is ventral side. There is the corpora spongiosum, which has the urethra as part of the corpora spongiosum. There are also dorsally and ventral. There are blood vessels. The dorsal arteries of the penis run on the dorsal surface along with the veins, and the neurovascular bundle runs on the dorsal surface of the penis.
So what are the coverings in sequence? Let's start off with the corpora cavernosa. What are the coverings? If you move within outwards.
Yeah, within outwards, the corpora cavernosum is surrounded by the tunica albuginea, and which is also the internal fascia, deep fascia, and then there is the superficial fascia, which is also known as the buck's fascia, on the outwards, and then there is the skin.
Superficial fascia is not buck's fascia.
And then the skin, dartos and skin.
Superficial is not the buck's fascia, actually.
So it was a fascia collis. Perineal fascia extension.
Perineal fascia is called fascia collis. Absolutely right, as Professor Shah said.
Yes.
So if you move outwards, it's first the tunica albuginea, then the buck's fascia, which is a very stiff fascia, which
Yes.
actually contains all the dorsal vasculature of the penis, and it actually splits on the ventral aspect to surround the corpora spongiosa.
Yes, sir.
And then on the surface of all that is the Colles fascia, which is a continuation of the fascia from the perineum. Okay.
Yes, sir.
So what are the structures that hold the penis up?
There is the suspensory ligaments, which come from from a sling over from a sling which suspends the penis. They're also attached to the crura and the bulb of the penis. The crura of the penis, which is in the root of the penis, which is also the istiocavernosus, is attached to the istiopubic rami. And then the suspensory ligaments, and the bulb of the penis, which is the bulbous spongiosum.
What is the fundiform ligament then?
The fundiform ligaments. I've heard the name, so I can't remember it.
Well, that's the condensation of the fascia of the subcutaneous tissue, which actually extends from this abdominal musculature up to the penis. So the importance is that the suspensory ligament carries the vein. The fundiform ligament is relatively avascular. So what is the blood supply of the penis?
The blood supply. There is the dorsal arteries of the penis. There is the deep arteries of the penis, which both arise from the internal pudendal arteries, and the veins which is a paired veins. Which
how is the corpus spongiosum supplied?
The corpus spongiosum is supplied by
Right to that?
The bulbourethral artery. The bulbourethral artery.
Branches of the internal pudendal.
Yes, sir.
Okay, sir. And what about the venous drainage? And what happens to the artery is that it splits into a dorsal artery and
a dorsal artery, and it circulates around the glans of penis and meets at the frenulum, which forms the frenular artery.
What is the other main branch of the internal pudendal after giving off the bulbourethral vessels? You've got the dorsal artery and the other one, a very important artery.
Deep artery of the penis.
Yeah. Deep artery, which you would find situated inside the corpora cavernosa, isn't it? Yes. So what about what is the venous drainage?
The venous drainage is in a paired drainage, and that empties into the prostatic venous plexus.
Do you have any outflow into the saphenous?
Not sure, sir.
Where the superficial dorsal vein goes?
I'm sorry?
The deep dorsal vein of the penis drains to the posterior venous plexus.
Yes, sir.
There is another vein known as superficial dorsal vein, which coming to the root of the penis, divides to the right and left branch, and drains into the great saphenous vein. This
via the pudendal branch.
Pudendal.
Okay. Yes. What about the nerve supply?
The nerve supply. So I can't remember.
Okay, you have the pudendal nerves, which actually supply the skin of the penis and the shaft of the penis, but you have a parasympathetic supply as well. The spinal root, do you know the spinal root for the nerve supply of the penis?
S1.
It's 2, 3, 4 actually. Okay, fair enough. But you also have a parasympathetic supply around it, which actually is a leash of nerves which comes along the cavernous veins. Okay. So you have a parasympathetic supply as well, which is responsible for the erectile function of the penis. Okay. Right. Now, how are you going to stage this disease, Madhavika?
Before staging, Madhavika, yes. you have commented at one point, the temperature of the ulcer is normal.
Yes, sir.
When you go for ulcer examination, don't comment about the temperature. You understand? You cannot appreciate the temperature of an ulcer. Okay, you can comment about the temperature of adjacent area, not the ulcer area.
Okay, sir.
Okay, so that comment is not required. And
Okay.
second is, you said patient has got secondary phimosis.
Yes.
Once a patient has got a secondary phimosis, it is not possible to give an exact dimension of the mass.
Yes.
Yes,
Because
sir.
in that case, you have to say, as the skin cannot be retracted, the proximal margin of the growth cannot be ascertained. And
Okay.
on palpation, you can feel the induration up to the corona glandis. Because you
Okay.
cannot give an exact dimension unless you do a dorsal slit. Okay,
All
that
right.
is the point you should mention while you examine the patient,
Right.
because patient has got a secondary phimosis.
Okay, sir.
Okay,
Yes.
okay. So, diagnosis.
My provisional diagnosis is a non-healing ulcer on the glans penis, most likely carcinoma penis without any nodal or distant metastasis.
Okay. So, as now Dr. Bukshi has asked of the staging, where do you place the patient? If you go by first TNM staging?
By TNM staging, I would stage the patient as N2, N0, M0.
N2?
N2 because of the involvement of the corpora spongiosum, so the glans penis is corpora spongiosum.
And there's no N2. You
It's
talk of TNM. You see,
TNM.
now then, if you go to the 8th edition of HSCC, it is
Okay.
not possible to give a clinical TNM staging unless you have done a biopsy.
Unless you've done a biopsy, yes.
Okay, so just a clinical staging of penile carcinoma cannot be offered at the end of clinical examination. So
Alright.
to offer a proper clinical staging, you need to have the biopsy done.
Okay.
Because some points in the biopsy specimen comes in the assessment of T.
Yes.
If you just go by your clinical assessment, what T should be? You said corpora cavernosa is not involved.
Corpora spongiosum is involved though, sir. So
Yes.
corpora spongiosum involvement comes
And
under
any urethral symptom, you said no.
No, sir.
So it should be?
So corpora spongiosum involvement comes under T2.
Corpora spongiosum involvement?
It comes under T2, sir.
Okay. And what else comes? What is T1 then?
T1 is involvement of the subepithelial connective tissue, which is divided into T1A and T1B. T1A is without any lymphovascular perineural involvement, and T1B is with lymphovascular and perineural involvement.
Yes.
So you see, Malavika, that exactly demonstrate the point that Professor Shah was trying to say. If you're asked about the staging, you cannot do a TNM staging without a biopsy.
Okay,
You
sir.
realize that, isn't
Yes.
it?
Okay.
If you're talking of perineural invasion and lymphovascular invasion, you cannot do that on clinical examination, isn't
Yes.
it? There
Yes,
used to be something called a Jackson staging, which is used to be practiced. Do you know what the Jackson staging was?
No, sir.
One was a tumor in the glands or prepuce or both. Grade 2, stage 2 was tumor extends to the shaft of the penis. 3 was where you had operable, in addition, you had operable linguinal lymph nodes. And 4 was when you had inoperable, clinically inoperable lymph nodes or involvement of adjacent structures. So that was the clinical staging that used to be practiced. Till the 8th edition, TNM came in. And for the 8th edition, you have to say, I cannot stage till I've got a biopsy. That's what Professor Shah has said.
Okay, sir.
And what are the end status in HSCC?
N0.
N0 here. So, what are the different end categories in TNM staging?
N0 is no lymph nodes palpable. NX is primary, the lymph nodes cannot be assessed. N1 is when there are less than 2 unilateral inguinal lymph nodes. N3, N2.
Mobile node.
Mobile lymph nodes. N2 is when there are more than 2 mobile or fixed unilateral or bilateral lymph nodes.
Not fixed. Fixed is not N2. Fixed is not N2.
Fixed
N2 is N2. more than 2 unilateral or bilateral.
Unilateral or bilateral lymph nodes.
It should be mobile.
Mobile. It has to be mobile.
N3 is fixed node.
N3 is fixed lymph nodes.
or
inguinal or pelvic lymph node.
or extracapsular extension.
Extranodal invention. Yes.
Extranodal extension. Yes, that is the nodal status. So
again, that becomes a pathological staging, isn't it, Malavika? So
Yes.
your answer, if you're asked about the staging, that I cannot do a TNM staging without a biopsy.
Okay, sir.
Right. So you have a primary tumor out here. You've done a biopsy, and the biopsy confirms that this is a stage T2. So
T2.
how would you proceed? What would you do about the nodes?
About the nodes, I would like first for the nodes, I would like to get an sonography of the bilateral inguinal nodes, bilateral inguinal regions, to see if there is any non-palpable lymphadenopathy. If there is any non-palpable lymphadenopathy, I would ask to get an FNAC of the involved lymph node to assess if there is any metastasis.
if it is a non-palpable node, is there any role for a sentinel biopsy in CA penis?
Yes, so there is a node for sentinel biopsy if there is the provision in the respective institute.
Yeah.
So what do you use for a sentinel node biopsy?
We can use technetium-99 colloid, or we can use isosulfan blue dye.
Okay. Sometimes you can use both as well, isn't it?
Yes, sir.
If you've got an impactful node and a T2 lesion, is there any other thing that you might want to do?
Additionally, I would like to get a complete metastatic workup done, which is an HRCT chest, abdomen and pelvis, preferably with contrast, if feasible.
Let me address it slightly differently. You've done a digital sentinel lymph node biopsy, and you found micrometastases. So what are you going to do there?
I will do a bilateral inguinal lymph node dissection.
If there's micrometastases only in the digital, in the sentinel lymph node biopsy, there is an issue, because suppose if you have micrometastases in the sentinel node, there might not be any other lymph nodal spread. Okay. It's if you have macrometastases, then you proceed on further. You have to proceed on to a therapeutic lymph node dissection.
Okay.
Okay, on the side that you've done it.
Malavika, I don't think CT chest is a staging workup for CA penis. It is not. You can ask for a CT scan abdomen,
yes,
and the groin area to assess lymph node metastasis. Okay, it's not usual to have liver metastasis also in CA penis, and CT chest is not a routine recommendation for staging workup of CA penis. Okay, unless you have a very advanced disease with some symptoms, it's not a routine. Is there any role for investigation to the local staging? You said clinically, you said the shaft is not involved.
yes.
Is there any investigation which can help in assessing the penile shaft involvement? It's not in the book, but it's coming up in some study reports.
Absolutely.
I don't know, sir.
Okay, the people are saying that if you give a prostaglandin injection, the penis get erected, and you do a MRI, that gives a very good delineation of any shaft involvement from the penile growth. Okay. Ultrasound also can sometimes help for the local staging. So for local staging, if there is a doubt, you can do a MRI, which can give a local staging.
All right, sir.
Okay, but CT is not.
Particularly with a ferromagnetic contrast that's coming in a big way, as Professor Shah said.
Yeah. Okay, sir.
So how you proceed with this patient? How you proceed with this patient for management?
Firstly, I would like to confirm my diagnosis with a biopsy, and I would additionally like to get an ultrasonography, like I mentioned, of the inguinal regions to assess for inguinal lymphadenopathy. I would also like to get a CT scan of the abdomen and the pelvis, preferably with contrast, to assess if there is any pelvic lymphadenopathy or any distant metastasis. And then I would like to prepare the patient
How will you take the biopsy in this patient? This patient has got a secondary phimosis. So
Yes.
if most of the cases, if there is secondary phimosis, you see the PPCL orifice is very narrow, and you may have some amount of growth coming out through this orifice. So
Yes.
how do you take a biopsy in this situation?
The biopsy would you take an incisional biopsy or a wedge biopsy from the
From where?
junction of the normal and the abnormal tissue.
The major part of the growth is hidden under the you have not shown us a picture,
Yes.
but if you say patient has got a secondary phimosis, most of the growth is hidden within the superficial skin.
Yes, sir. So we will first perform. We will do a dorsal slit or do a circumcision, so we can just use the
No,
entire.
formal circumcision is not required. You see,
Well, not a
formal
circumcision.
formal circumcision is not required. You have to do a dorsal split, and from which area of the ulcer you take a biopsy?
From the junction of the normal and the abnormal tissue, so the edges
Why?
of the.
Why you take the biopsy from the junction area?
Because the center of the ulcer is is more bound to be have necrotic tissue, so will give us the histopathology specimen will not be sufficient. So the edges will have the proliferating margins, so we will be able to.
So towards the edge, you find the most proliferating margin of the tumor is the junction of the normal tissue.
Yes,
That is the reason. Okay. So the report now is back saying that patient has got a high grade 3 tumor
okay, sir.
with lymphovascular invasion.
Okay, sir.
So why do you place this patient into low risk, intermediate, or high risk patient?
I would place this patient in intermediate risk because the primary lesion is intermediate risk. Yes, sir. Intermediate risk because he has a low volume of primary lesion, but it is high grade and he has no lymph node metastasis.
In view of the risk of metastasis, this should be taken as a high risk because it's a grade 3.
Yes.
Is a grade 3 lesion with lymphovascular invasion.
Yes.
So if both are present, this is a patient the high risk of having lymph node metastasis. So he should be considered as a high risk patient. Okay. Yes, Dr. Bokshi.
Yes, Malavika, suppose this patient now, just changing the scenario, had a palpable lymph node. So how would you proceed?
If he
It
has
was a mobile lymph node, a mobile unilateral, a single lymph node in the left inguinal region, for example. How do you proceed?
If he has a mobile single unilateral lymph node, I would first like to get an. There are two modalities of management of this patient.
What would you do?
The more preferable one is to get an FNAC of the involved lymph node and confirm if there is any metastasis in the lymph node. If there is metastasis, then we will proceed with bilateral inguinal lymph node dissection along with the surgical treatment for the primary lesion.
If the FNA is negative?
If the FNAC is negative, we will treat with broad spectrum antibiotics to see if for six weeks to see if it's just a reactionary lymph node enlargement, and if that subsides, then
in the interim, would you address the primary tumor?
In the interval, I would address the primary tumor. Yes, so I would proceed with the surgical management of the primary tumor.
And then treat this patient with antibiotics. Now, the antibiotics, the node hasn't gone. It's still as big as it was, slightly larger. Now, what do you do?
I will repeat an FNAC of the inguinal lymph node to see.
Again, negative?
Again, negative. Then I would go for it is a modified inguinal lymph node dissection.
Now you grade the patient. Now this situation, repeat if it is negative, if the patient is of not having other risk factors like no lymphovascular invasion, grade is grade 1. In that case, you can keep on surveillance.
Okay.
But high risk patient with lymphovascular invasion and a high grade tumor, they are the patient having high risk. In that case, you should consider the patient elective Superficial,
Superficial
elective,
bilateral
superficial lymph node dissection. Yes. And subject this to the frozen section.
Frozen section, absolutely.
And if the one side is positive, we do the deep node dissection the same side.
Yes, sir.
Okay. So this will be guided by, now the question of giving a blanket antibiotic is not recommended. If the nodes are palpable, you have to address the node by doing investigations up to a image guided biopsy.
Okay, sir.
And then decide.
Okay, sir.
What surgery you plan for this patient?
For this patient, I would go for a partial penectomy with sentinel lymph node biopsy if the for the current scenario, initial scenario. I will with the yes, sir, with the sentinel lymph node biopsy. If there is sentinel lymph node positive, then I will go for bilateral inguinal lymph node dissection along with partial penectomy.
What is the indication of pelvic node dissection in CA penis?
Indications for what, sir? I'm sorry.
Pelvic node dissection. You say one side is positive, you will do inguinal dissection. When do you consider doing a pelvic node dissection?
Pelvic lymph node dissection will be done firstly if the pelvic lymph nodes are palpable or if they are seen on imaging like on CT. Thirdly, if there is bilateral bulky lymph nodes, then and if they are fixed, then I would to be on the safe
fixed node is not the case for operation. I'm saying you find the groin node is positive. There are some indications for doing extending the incision to a pelvic dissection. If you have more than 3 nodes being positive, if there is extranodal extension, and the deep inguinal node is positive, cloacated node is positive. In that cases, there is higher risk of getting pelvic node being involved. So in that case, you should consider on one side inguinopelvic and the other side you should a superficial node dissection.
Yes, sir.
So these are the few indications for doing a added excision of the pelvic nodes.
Yes, sir.
If, for example, on the contrary, Malavika, you had a, let's say, a T1A disease.
Okay.
Is there any other surgical alternative or any other non-surgical alternative for a T1A node negative patient?
Patient is refusing to undergo amputation.
T1A. If there is T1A, since it's a low risk, I can also go for glandsectomy if it's the tumor is confined to the glands. And if the tumor is confined to just the prepuce, even a circumcision can be curative. And there is also there is a new modality.
He want no surgery. The patient is refusing surgery.
Refusing surgery.
Any other option?
Surgery. There are topical treatments of 5-fluorouracil and imiquimod, which work for very selected cases. And
T1 lesion is not for topical application. Topical application is for TIS or TA lesions.
TIS or TA.
T1 lesion will not be amenable for just topical application. What else can be done? There are other modalities of treatment now.
T1A, we can also go for laser therapy.
Yes. Laser ablation and
Laser ablation.
And
something else.
And radiotherapy.
Radiotherapy.
Yes, which can be either a brachytherapy or a teletherapy with linear accelerator. So you should know the other options. You see, the standard of care is doing a partial penectomy or glandsectomy.
Yes.
Now, with advent of newer modalities, more and more organ preserving treatment is offered to the patient. So there are some penile preserving options for this patient of carcinoma penis. So that is applicable when you have early lesions. What are the different ways you can apply radiotherapy to the penis?
There is brachytherapy and there is external beam radiotherapy. It should only be done after circumcision, so to prevent any radiotherapy local complication like phimosis. And we can give brachytherapy with an intervening pelvic brachytherapy or radiotherapy, external beam radiotherapy.
Brachytherapy can be either you apply radioactive wire, or you can ask the patient, you can apply a mold
Mold.
Mold.
which can deliver high dose radiation locally.
High dose local radiation. Right. So, I mean, what if you were doing surgery? What is the rationale for using adjuvant chemotherapy?
Adjuvant chemotherapy is given to downstage the tumor to reduce the size, to reduce the bulk of the lymph nodes. If there is palpable lymph nodes, and I will give chemotherapy to downstage the tumor to decrease systemic.
What is used? What is used
micromantle.
for as adjuvant chemotherapy?
5-fluorouracil, cisplatin, and ifosfamide.
Actually, paclitaxel is used. It's called the TIP
Regimen, yes. Sir.
TIP therapy. Fair enough. Professor Shah, do you want to go in for because we've got 15 minutes left? Do you want to go in for the total penectomy?
Yes. Yes. So, what are the important risk factors for development of carcinoma penis?
The risk factors, the most there is poor hygiene. There is lack of neonatal. If neonatal circumcision is potentially protective, so neonatal circumcision, poor hygiene, which is lots of sperma.
That is not risk factor. The point is phimosis. If a phimosis, that is one important factor for high risk for developing carcinoma. One is phimosis. What else?
Balanitis.
Yes. Chronic inflammation in the penis.
Yes, sir.
Recurrent melanocytitis. What
yes,
else?
Sir.
Any other factor?
HIV and HPV infection, chronic smokers, lichen sclerosis, which is a lichen sclerosis, leukoplakia, erythroplasia of Curad.
Yeah. So they are the important risk factors. Okay,
what
I think we can go for the steps. Yeah.
What is Bowen's disease, Malavika?
Bowen's disease is penile intraepithelial neoplasia, which is the carcinoma in situ version, carcinoma in situ stage of carcinoma penis, squamous cell.
Where does it affect the penis?
Most commonly involves the shaft of the penis.
Why is that?
I'm sorry?
Why is that? You're right, but why is that? Absolutely right. But why is that?
I don't know, sir.
It affects the follicle bearing areas.
Okay,
the glands doesn't have any hair follicles. Okay.
Okay. I think you can discuss the operative part. Okay.
Yes.
So in the short case, you also discuss we are not discussing the partial amputation, which is a very simple operation. But in some situations, there are indications for doing total amputation. Yes. So tell us the indication for total amputation of penis.
The indication of the total amputation of penis is when the primary lesion involves the proximal part of the penis, or if the negative margins of the primary focus, primary lesion will not be able to provide a sufficient length of penis for maturation and for sexual function, then we would prefer a total amputation of the penis.
What is the standard recommendation for having a clear margin?
Clear margin is 1 centimeter for squamous cell carcinoma, but it can be 1 to 2 centimeters. 2 centimeters is usually
the standard recommendation is 2 centimeter. Now people are saying that is a well differentiated tumor.
Yes, sir.
You can go by up to 5 millimeter to 1 centimeter. That's true. But usually standard description is 2 centimeter clear margin for the proximal margin of the tumor. Okay. So describe the steps of total penectomy.
I will take informed consent from my patient, and I will prepare him preoperatively as for surgery. Then I will, during the surgery, he will be, the position is a low lithotomy or lithotomy Trendelenburg position. I will prepare the penis with povidone iodine solution, depending on the extent of resection. If we are going to do an inguinal lymph node biopsy, I will also expose the inguinal region. We'll be kept in a low lithotomy position. After preparation, I will first introduce
Malavika, Malavika, I'm just going to suggest that if you have the patient in lithotomy, that's not a very ideal position for doing an inguinal node dissection.
Yes, sir. But for the total penectomy part.
Yes, yes. So stick to total penectomy.
Okay. So total penectomy. I will first introduce a metal bougie into the urethra. Then the incision is a tennis racket shaped incision which is encircling the penis and extending into the midline of the scrotum right up to the perineum. The incision stops at a point which is equidistant from the scrotum and the anus. I will extend the incision deep in order to expose the crura and the bulb of the penis. After that, I will extend it in the scrotum, in the midline. I will extend it till the perineum. In the root of the penis, I will first detach the crura of the penis from the ischiopubic rama using.
You need to first mobilize the penis, the shaft of the penis. There are two structures.
Yes, so I will dissect till the
suspensory ligament. Being careful of the vein that drains into the prostatic venous plexus, which usually runs along the suspensory ligament and the fundiform ligament.
Yes, sir.
Having done that, it's traditional to go into the cave in between the angle of the lower inferior angle of the symphysis pubis and take the fat down, isn't it?
Okay.
And then you address how do you take the corpora cavernosa of the ischial ramus.
I will take the corpora cavernosa by using a raspitory, and I will shave off the corpora cavernosa. I will preserve the.
So you lift off the periosteum, isn't it?
Periosteum, yes, sir.
Actually, that is radical penectomy. If you are talking of total penectomy, you can excise the corpora cavernosa at its junction with the root of the crus. Okay, that is a step for total penectomy. If you are doing radical penectomy, you have to strip off the periosteum from the ischiopubic rami. Okay, otherwise you can disjunct the corpora cavernosa at its junction with the root of the crus.
Okay, sir.
And what artery comes here?
What artery comes in?
The dorsal artery. The dorsal.
No. The crus of the penis artery pierces this. You say it in the arterial supply. That artery was what? Deep artery of the penis.
Deep artery.
Deep artery comes into the corpora cavernosa through the crus of the penis.
Yes, sir. So I will ligate the deep arteries of the penis and.
I ligate, or you can cauterize also, no problem. So you disjunct the corpora cavernosa at its junction with the crus of the penis.
Yes, sir.
And then testis hangs with what now?
Yes, sir. I will preserve the corpora spongiosum for a length of 2 inches or approximately that can be mobilized into
Not 2 inches. 2 inches is too much. 5 centimeter.
5 centimeter.
No. It's not 2 inches. It's 2 to 3 centimeter.
2 to 3 centimeters. 2 inches is too long.
2 to 3 centimeters. And I will put that. I will place that in the perineum. Take it caudally into the perineal region. Then I will dissect in the perineum. I will remove a 1 centimeter, approximately 1 centimeter margin of skin and subcutaneous tissue in order to make place for the urethra. And the urethra, I will spatulate onto the surface of the skin and suture with absorbable sutures to prevent any urethral stricture, and also continuously irrigation to prevent any ischemic complications. And the drain is kept in situ in the scrotum to prevent any hematomas. And I will the scrotal incision I will close transversely in order to lift up the scrotum from the perineal region.
And
put
a catheter?
Catheter is placed in the urethra.
Now, this patient has very large testes, and finds that passing urine subsequently is a problem. So can you anticipate for something and do something about it? Has a large scrotum.
The incision on the penis will be closed transversely instead of longitudinally.
So that hitches up the testes
Put
in
up the
front.
scrotum. Yes, sir.
In front.
Yes.
And if it's very large, sometimes there is a scope for implantation into the medial side of the thigh as well. Professor Shah, any other questions?
Yeah. What are the complications of total amputation of penis?
Complications are wound infection, hematomas, and the most common complication is urethral stricture. For minor urethral strictures, we can
Before stricture, you can have ischemic problem.
ischemic changes.
Before stricture, immediate post-op, there will be problem with the blood supply of the
Yes.
stomach.
Yes.
And then subsequently, in the long run, there may be stricture in the. How do you manage the stricture?
A minor stricture, I will manage with, I will ask the patient to use self-dilatation. And if there is a major stricture, then we will have to go for stricturoplasty. Or intraoperatively, we can also use a ventral inlay technique to prevent stricture formation.
You can patulate. You can cut the urethra on either side and patulate this anatomy with the skin.
Yes, sir.
Okay, it's a short case. We have a good discussion.
Yes, yes, yes.
The main important part is your presentation should be good and your approach to the patient should be good.
Okay, sir.
Thank you, Malavika. Thank you. Thank you.
Okay. Dr. Maiti? Dr. Shukumar Maiti, any question? Oh, yes, later. Dr. Maiti?
Professor Saha and Professor Buxi, it was a wonderful class. I could comment, and I was taught to keep up, but whatever I have heard, excellent and superb discussion, and I congratulate the student also who presented the case and interacted. Excellent.
He presented very well. Yes, very good. Malavika, keep it up.
Thank you, sir.
Good. Well done, Malavika.
Thank you, sir.
Thank you.
Thank you.
See you on Thursday. Okay. Thank you.
Thank you.